नमस्कार. प्रुडंट मिडियाच्या हॅलो दोतोर कारण तुमकां सगळ्यांक मना काळजासान येवकार. आज तुमकां येवकार दितना मन उर्बेभरीत जाता कारण आमचे बरोबर जे आसा डॉक्टर ते ऑल द वे ही हॅज कम फ्रॉम लंडन. बेसिकली ही हॅज स्टडीड इन गोवा मेडिकल कॉलेज. तांचें नांव जावन आसा डॉक्टर थॉमस सॅम्युएल आनी ही इज अ पेन मॅनेजमेंट कन्सल्टंट इन UK इन अ बीग हॉस्पिटल बाय नेम लिस्टर हॉस्पिटल. सो एक येदो व्हडलो मनीस आज आमच्या कार्यक्रमांत सहभागी जाता. खरें म्हणजे आमच्या कार्यक्रमाची उर्बाय वाडटा आनी त्यातून आमकां एक खोस आसा की आमच्या ह्या कार्यावळीन हॅलो दोतोर कार्यावळीन अशे इंटरनॅशनल रेप्यूटचे डॉक्टर्स आमच्या मदीं सहभागी जातात. आपलें ज्ञान आमच्या मदीं वांटपाचो प्रयत्न करतात. आमकां एक ज्ञानाची एक नवी उर्बा दितात, नवे किरणां आमच्या मुखार उक्ती करतात आनी अशाच एका सुंदर कार्यावळींचो तुमकां येवकार दितना डॉक्टर वेलकम. नमस्कार.
Thank you very much.
First of all, I welcome you because if I faintly remember, you must have left Goa in something around 1987.
Yes.
Because you are my some years senior to me. So if I recollect that batch, which was a very enthusiastic, dynamic batch, I still remember you as a very social, culturally active person and always busy in a lot of activities apart from the studies. So that Dr. Thomas and today's Dr. Thomas and it is not me also. A lot of changes have occurred right from our hair to everything, body structure. And really I'm feeling happy that you have shown your willingness to participate in this program. Topic what you have decided for today's program is pain management, which is your favorite topic as you are working as a consultant in pain management in Lister Hospital. So basically, doctor, let's come to first thing what I would like to know. After you left Goa, how was your journey and where was your journey and how you landed up into the pain management?
Thank you very much. First of all, thank you for the very generous introduction, which I'm not sure that I deserve. But thank you very much. There are much brighter luminaries than me who have left Goa Medical College. And yes, we've changed a lot. Receding hairlines and protruding waistlines have brought about a difference to us. I left in 1987, found myself doing a few house jobs in Just Look Hospital. After a year and a half, I joined for anesthesia training at Lokmanya Tilak Municipal Medical School in Sion. And that's where I did my diploma anesthesia as well as anesthesia and critical care training, which I finished in 92. And then in 93, I decided to venture further away and ended up in the UK, did various training jobs in a number of different hospitals, including Bedford, Leeds, and in the process got my diploma anesthesia from London and then did my fellowship of the Royal College from the Royal College of Anesthesia in London and decided to also attempt the Irish exams and got the fellowship from the Royal College of Surgeons of the anesthesia faculty.
So it is really a very prosperous academic journey which you have gone through. I must say. In fact, I'm feeling honored that I'm sitting with such a bright luminary who has done such an excellent job in this field of medicine, I would say, at large.
Not at all. And then I took up a consultant job and did anesthesia and critical care for a number of years. And then about 15 years ago, moved into pain. And now for the last 5 years, I'm exclusively practicing in pain medicine as a consultant.
Achha, so it is really I should say that you have chosen the right field because finally I always say people go to doctor only when there is a pain. In fact, I have one logic. I always say the thing like whatever doesn't pain is more harmful for the simple reason, like let's talk about breast cancer or cervical, which are subject to my related this thing. Ladies, they know that there is some lump, but since it doesn't pain, they don't go to doctor. Ladies know that they are having some discharge which is not so regular or not a normal type, but since it doesn't pain, nobody goes to doctor. So on the contrary, suppose somebody has a toothache, he or she, even whether poor or rich, go to the nearest doctor in possible ways, whatever Ayurvedic, homeopathic, whatever he may be, and get treated. And I always say, see, with toothache, nobody has died. This is my information.
That's
general.
True. Yes.
Or even some you get some boil, which if it is furuncle or this thing and carbuncle, but if it is paining, then they go to doctor. Yeah. But when the pain you don't perceive pain, it is more dangerous. So first of all, my first question, what do you mean by pain? And what is the perception of pain means?
Thank you very much for asking that question. It's an interesting one that pain is a universal phenomenon that every human being goes through at some stage in their life. Absolutely. For of course we are born in pain, and we most probably might die in pain, though our endeavor as pain consultants would be to ensure that that is minimized as much as possible. Correct. Of course. And this is the problem with pain. Pain has been defined actually as a complex, unpleasant, sensory and emotional experience associated with tissue damage or sometimes without tissue damage. And this is where the conundrum is, because we can see a lot of patients who have no obvious tissue damage and yet they are in pain. And the entire pain experience is modulated and the perception is modified by our central processing unit, the brain. And that depends on many factors such as your past experiences, your childhood experiences, your learned behaviors, your expectations. And therefore it becomes challenging because my pain is not your pain.
Absolutely. दोतोरान सांगलें एक महत्वाचो स्टेटमेंट असो केला की जे म्हाका दुखता ते तुमकां दुखतले जशें न्हय. जशें आमी आतांच म्हटलें की समजा एक दात दुखता जाल्यार म्हाज्या दाताची दूख तितकीच जरी आशिल्ली, तितकोच जरी इन्फेक्शन असलें जरी सो तुमकां तितके परसीव जातली जशें न्हय. सो प्रत्येकाच्या पेनाचे म्हणजे दुखीचे डेफिनेशन वेगळे आसता. दर फावटी ताका पॅथॉलॉजिकल कंडिशन आसता जशें न्हय. केन्ना केन्ना आपले पास्ट एक्सपिरियन्स किंवा आपले भोंवतणचें वातावरण ह्या सगळ्यांचेर डिपेंडंट अशें आपलो एक मनाची एक आपली प्रतिक्रिया आसता, जाका ब्रेन हो मेन म्हणजे मेंदू हो मेन सेंटर आसता, ताचे वरसून ते आमी प्रतिक्रिया व्यक्त करता की म्हाका हें दुखता किंवा दुखना. की तें सांगलें न्ही, एखाद्या समज आमी एक 10 किलोचें एक समज वजन एका मनशाचेर 2 इंचाचेरसून दुखल्लें जाल्यार सगळ्यात म्हणजे तितकेच दुखतलें अशें न्ही. एकट्याक चड दुखतलें, एकट्याक कमी दुखतलें, एकट्याक दुखचेंच ना. सो दॅट डिपेंड्स ऑन पर्सनल ताचे कितके टॉलरन्स आसा, ताचो कितलो एक्सपिरियन्स आसा आनी हांव हे म्हणजे ताका तो कशें कोरिलेट करता. केन्ना दॅट कोरिलेशन ऑल्सो इम्पॉर्टंट बिकॉज if he has seen something which aggravated by that much, he will say, oh no, it's painful. Otherwise, no, that's kind of dukana. Because after suppose now if I say I'll give you one blow and after that I'll going to give you one ice cream, you'll say okay, chalta hai. Just as a kid I'm saying.
Yes.
So that's how the full phenomena goes. But doctor, one more very interesting. What I have learned is that brain doesn't perceive pain. What do you mean by this?
So let's talk about in a sense, how does one perceive pain?
Yeah.
So what we have is we have receptors all over our periphery, which are known as nociceptive receptors. Now they perceive tissue damage, potential tissue damage, temperature, cold, all of those changes. And those impulses travel along the nerves into our spine. There it gets modified slightly, goes up along the spine to the brain. Now you ask the question, is there a pain center? No, there isn't. But there is a number of regions in the brain and we call that as the pain matrix.
Achha.
Because we know that various areas of the brain are involved. Once the pain reaches there, it is modulated by our experiences. And then we have what is known as the descending pathways, which also are either inhibiting or exacerbating the pain. And what do I mean by the brain modulating it? We could have issues such as, did you have any painful experiences during your childhood? Were your family overtly concerned whenever you were in pain, or did they ignore you when you were in pain? Are you in a depressed state of mind? Are you in a happy state of mind? All these impact on what we perceive as pain, and that is the perception of pain.
हो. सो एक व्हेरी इंटरेस्टिंग खबर आहे डॉक्टरांनी सांगलें की आमी ताका दूख किंवा म्हणटा किंवा पेन अशें जाका म्हणटा ती मल्टीफॅक्टोरियल आसता. म्हणजे तातूंत जशें डॉक्टरान सांगलें की आमचे सगळे रिसेप्टर्स आमच्या सबंद आंगभर असतात. ते एका पर्टिक्युलर पाथवेंतल्यान ब्रेनाच्या ज्या स्पायनल कॉर्डांतल्यान वयर वतात आनी थंय एकच अशी जागा अशी आसना. जशें आमचे म्हणजे लायक सी स्पीच देर इज अ सेंटर, पळोवपाचें एक सेंटर आसा. अशें एका जाग्यार आसना, देर इज अ मॅट्रिक्स. म्हणजे ते वेगवेगळ्या जाग्यार अशें स्कॅटर जाल्ले आसता. आणि तूं कितकी पेन जे आपल्याक परसीव जाता, म्हणजे म्हाका कितकी दूख भोगता, सादे भाशेन सांगत जाल्यार हे म्हज्या मल्टीफॅक्टोरियल आसा. म्हजे पास्ट एक्सपिरियन्सीस कशे आसा, म्हजे पेरंट्सांनी म्हजेर कशा म्हाका पद्दतीन ट्रीट केला, ते ओवर कन्सर्न, दे आर जस्ट कन्सर्न, काय दे आर इग्नोर्ड, की नासूं ताका काय जायना अशें म्हणून केला. आनी अशें म्हजे पास्ट एक्सपिरियन्स अशें आसा की मातशी दूख जाल्ली पण मागीर इट हॅज इव्हेंच्युअली लेड इन टू सम डेंजरस ऑर क्रिटिकल थिंग वीच आय हॅव सीन अक्रॉस अराउंड इन माय फॅमिली. ह्या सगळ्या फॅक्टरांचेर प्लस म्हणजे मनाची अवस्था कशी आसा, वेदर आय एम इन अ डिप्रेस्ड स्टेट और वेदर मी इन अ हिलरियस स्टेट. आय से सपोज समबडी वॉन्ट्स अ टार्गेट, लायक ही इज क्लाइंबिंग अ माउंटन, दो देर इज सम पेनफुल स्टेट, ही विल से नो आय हॅव अ टार्गेट, ओके आय हॅव टू कंप्लीट. सो हें सगळें करतना तो तितकी पेन म्हणजे तितकी दूख आसा ती सोंसता किंवा तो ताचेर ओवरकम करता. Whereas if the reward is not so pleasant,
Yes.
definitely it can exaggerate.
Absolutely.
So हे जे आसा की जर रिवॉर्ड ताका तितकें नसता की फायनली मनीस हो असो आसता की एवरीबडी लायक्स टू बी इन अ प्लेजरफूल स्टेट प्लेजंट स्पेस फेज एंड नो बडी वॉन्ट्स टू एन्जॉय पेन. सो पेन कोणाकच नाका आसता, मनशाकच न्ही जनावरांकूय नाका आसता. सो हाचेर सगळे खाणांचें गणित आसा. इवन ह्युमन टेंडन्सीज अशी आसा की ऑल दीस पीपल वर्किंग इन HR दे ऑलवेज वर्क विथ दॅट स्पिरीट बिकॉज दे नो ओके दीस nobody will like to have that. So give this and take according. Means it is a gamut like what they structurally consider when they give out some rewards or take you something done from you. So हे सगळं करताना डॉक्टरान अतिशय सुंदर पद्धतीन सांगला की हे जे आसा सगळ्या मनशाच्या पास्ट एक्सपिरियन्स म्हणजे त्याचे पयलींचे जे एक्सपिरियन्सीस आसात अनुभव आसात ताचेरूय डिपेंडंट आसता. डॉक्टर when we say pain, you have said sometimes there is no tissue damage.
Correct.
And still that pain can occur.
Correct.
And you mentioned about something called depression.
Yeah.
What is the correlation? How the person in this state, or what is a real phenomena, or why he pursues pain? Is it because of his depression, or he wants to draw the attention, or what is your take on this?
Yeah. Okay. So, if we talk about the different, you talked about whether there was tissue damage or not. Let's talk about the different types of pain. So we have what we call as nociceptive pain, which is pain through damage to or stimulus to the receptors in the periphery. The second group of pain is called neuropathic pain, and that neuropathic pain is when there is damage to the sensory system. So either there is a compression of a nerve or there has been neuropathy due to illnesses such as diabetes, etc. And the other kind of pain is what we call as possibly nociplastic, where there is a lot of what we call central sensitization. So where a normal painful stimuli would elicit a certain amount of pain, in somebody who's sensitized, that threshold has changed, and for them they perceive it as much more. And
pain.
this is dependent on how much sensitization has occurred in the brain to pain. Talking about how your mental health status affects pain, there are numerous neuronal circuitries in the brain which all act through different pathways. Now we know that distraction helps with pain. If you distract somebody, they don't see pain as they don't perceive it as much. In a simple, for instance, we use something called as a TENS machine, which is transcutaneous electrical stimulation. What that does is, normally pain travels through A delta and C fibers. This one stimulates the A beta fibers. Because of that, that changes the modulation at the spinal level. So those pain impulses are not going to the brain.
I see.
So there is a modulation. Now, with regards to how whether you're depressed or happy, it appears that those are dependent on the amount of neurotransmitters in the brain. So the amount of dopamine, the amount of serotonin, the amount of norepinephrine. And if your levels of these vary, then the pain that you perceive, it changes.
अच्छा. सो डॉक्टरांनी खूप सुंदर पद्धतीने आमकां सांगला की ज्या पद्धतीन तुमी इथं पेन तुमचे वता तेन्ना ब्रेनातले जशें वेगळे त्यांनी सांगले नॉरएपिनेफ्रिन आणि हे सगळे जे फॅक्टर्स आसा सेरोटोनिन हे सगळे दे कम इन टू पिक्चर आणि त्या प्रमाणे तुमकां ताचे ग्रॅविटी फील जाता एखाद्या मनशाक आणि डॉक्टर वन मोर थिंग आय जस्ट वॉन्ट टू आस्क यू सिन्स यू मेन्शन अबाउट दोज पाथवेज sometimes there is something called acupressure or acupuncture, whatever it is.
Correct.
And then suppose I have got pain in the spine,
Yes.
I mean on the shoulder, let's
Yes.
assume.
Yes.
Then he takes a pen and he keeps on pressing over here and
Yes.
it's the same phenomena what you are describing. Because of that, that pathway gets obliterated and then the pain, that pain is not pursued.
Correct.
When you, means there is one nice saying, एक दर्द दूसरे दर्द की दवा होती है.
This is the concept of pain inhibits pain. So simple example, if you hit something on your hand, what is the first reflex action? You take it and shake it about.
Correct.
Or you squeeze it or press it.
Yeah.
What you are doing is you are changing the modality of pain. So you're increasing another kind of stimulus which overcomes that pain stimulus. And that's exactly what happens. With acupuncture, it's a little bit more complex. To be honest, nobody knows exactly how it works. But we know that if you stimulate peripherally where the nerves run, and in fact, if you see a lot of the acupuncture points used in the Chinese, they really travel over the peripheral nerve pathways. And we know that there is retrograde transmission, and that does dampen down the pain.
So basically, you are not treated as such. Your pain perception is
Correct,
lowered.
correct.
That is the more correct.
Or the stimuli being transmitted are
is-
decreased
is decreased.
or
So
modulated.
basically आम्ही खूपशे फावटी अशें जेन्ना पळयता तेन्ना तुमी तेमकां दुयेंस तुमचें बरें जाल्याचें न्हय अशें समजा की आमच्या धोकराक सूज आसा अशें समजुया आनी तें दुखता जाल्यार तुमी दूख जी परसीव जाता ती कमी जाता पण तें धोपर बरें जालें अशें आमी म्हणूं शकना करेक्ट सो सेम वे आनी डॉक्टरान खूब पद्दतीन सांगलां की ज्या पद्दतीन ते पेन फायबर्स वतात आनी ताचे एक स्टिम्युलस आसता तो आनीक डॉक्टर सी समटायम्स सपोज आमकां स कळ्ळें म्हाका धांवताना कॅच आयलो एग्जाम्पल किंवा आमी खूब काम केलें देन वी अप्लाय सम लिनेमेंट कितें तरी आमी लायता खंयचे जे आमी तुमी टीव्हीचेर पळयता खंयचे एक वखद लायता जे खूब जळटा मे बी बिकॉज इट कंटेन्स डिफरंट टायप्स ऑफ मेडिसिन्स ऑन ऑल डिफरंट टायप्स ऑफ अदर what I should irritants
Yes.
rather than I'll say medicine.
Yes.
I'll put it as irritant. But we feel better. हाचो एक लॉजिक आसा यू मीन टू से दिस इज बिकॉज that irritant and counter irritant. What is that? What is that? How you place it?
The two mechanisms there.
Yeah.
One of them is that if you use something like capsaicin, which is a
Correct.
burning one,
Yeah.
that acts on the TRP receptors. So those receptors are affected, pain is affected there. So that acts there. The second one is the heat that it generates. Clearly, that is modifying the transmission of impulses because it's inhibiting some fibers.
Acha. So doctor, now let's come to pain management. Now, what are the pain management modalities today at your place, in our place, and how you manage pain at different levels in different types of things? Because now I want you to take the full liberty and explain to us everything.
Okay. So historically, pain, as with a lot of other medical fields, had one method that was the biological model of pain, which means that it is purely physiological problem. But we've moved away from that now. The way we treat pain is biopsychosocial model because we just explained how the definition of pain itself includes emotional and sensory, and therefore we have to treat. I almost hesitate in saying I treat pain, I treat the patient, because in a way you have to treat the patient.
Absolutely.
And the way we treat them is through a combination of interventions in the physiological aspect, in the psychological aspect, and in the try and adjust their social aspect. So if you take a simple, walk through the pain management field, we start with, let's say, simple medications. So we are talking of things like paracetamol, non-steroidal inhibitors. And then, so those are good for muscular pains. NSAIDs are useful for some amount of hyperalgesia, which means increased sensitivity to pain. And then you go up the ladder. So then you have things like weak opioids, like codeine. Then you come up to tramadol, tapentadol. Incidentally, tapentadol is allegedly the only new analgesic molecule in the last 25, 30 years.
Oh.
But actually it's just a refined version of tramadol. And then you have the strong opioids like morphine, fentanyl, oxycodone, buprenorphine, all that lot. Along with them, because pain medicine has been challenging, we have stolen drugs from other specialities. So we use from the neurologists a lot of anti-epileptics. So those are the gabapentinoids. So you have gabapentin, pregabalin. We use tricyclic antidepressants like amitriptyline. We also use the other drugs which are from the psychiatrists, the antidepressants, like duloxetine, venlafaxine, all these. Primarily those are for neuropathic pain, the other drugs. And then we go on to some rarer things like ketamine infusion, lignocaine infusions. These are, and of course the drugs can be given by a variety of methods, oral, injectable, patch, lozenges, all those kinds. So that's with the medications. Then we have the interventions. Now let's say you have a spinal, you've got back pain. Incidentally, back pain worldwide causes more disability years than even diabetes or COPD, which is phenomenal socio-economic burden apart from the personal suffering of the patient. We can use, epidural injections, facet joint injections, radiofrequency used ablation now of the facet joints. as well as pulsed radio frequency of dorsal root ganglion of the spinal canal. So a variety of those injectables or peripheral injections. Now with the explosion of ultrasound, we have huge amount of injections available to us. Moving one step further, we have then implanted neuromodulators.
I see.
So we put stimulators into the spinal cord and we stimulate the spinal cord to help with pain, particularly radiating down the leg in failed back surgery syndrome or diabetic neuropathy or chronic regional pain syndromes. I'm assuming you want to ask me what that is.
Yes, absolutely. Yes,
so,
absolutely.
So chronic regional pain syndrome essentially is ongoing pain with no specific reason for it to continue.
Oh.
This might be after an initial insult or it may be spontaneous. But it's characterized by, usually in the limbs, sometimes spontaneously, sometimes after surgery, sometimes after injury, severe, unremitting, ongoing pain associated with sensory symptoms, swelling, temperature changes, color changes, skin changes, the nails growing differently, sweating differently, etc. And finally ending up with being unable to use the limb, dystrophic symptom, that kind of thing.
So it is very severe pain.
It is a very severe condition. Many people, gradually it eases off, but some people it can continue to get worse.
Achha.
Yeah.
Doctor, now one more thing what really I'm interested in knowing is something called trigeminal neuralgia.
Yes.
What they say, textbooks say it is one of the worst pain.
It is.
And they also say that people commit suicide by repeated this thing of this. What do you mean by trigeminal neuralgia and what is the management? Since we have got another 3-4 minutes, I would like you to talk on this.
Trigeminal neuralgia is one of those really distressing kind of pains which is due to a number of different reasons which affect the trigeminal neuralgia. Now, you can have a blood vessel which is coursing very close to it and causing compression of the nerve. In that case, the treatment is easier because you can go in for gamma knife surgery or open neurosurgery where they can either put something between the vessel, blood vessel and the nerve. Sometimes you don't have it's a tumor which grows, then it needs surgery, but oftentimes we find no specific cause for it. And it results in lancinating, shooting, sharp, severe pain which lasts for seconds at a time but is so terrible.
So terrible.
And is triggered by wind, water, touching, anything. I mean, you're right, the people have been known to commit suicide. In short, what is the treatment? We can start from the neuropathic agents, and essentially in pain medicine, there's only carbamazepine is used only for this condition. Carbamazepine, oxcarbamazepine, lamotrigine, number of these. They do injections into the trigeminal ganglion region. We do radiofrequency, pulse radiofrequency. And in the most severe cases, then of course, they need surgery.
So doctor, I think we are almost done with the time. But before we conclude, I would like, since you are working for so many hospitals abroad and basically your roots are associated with Goa. Tomorrow, my appeal to you, at the same time, I would like to ask you, if you get an opportunity to serve this place or to be in Goa, how you will feel or what will be your take on this?
I think I would be honored. To definitely be able to offer some kind of support. It may not be on a permanent basis, could be intermittent. Correct. And if the powers to be at the Medical Council of Goa decide to give me registration, then that would be
sure, definitely. We'll hope and we'll try to see that you get registration. As many people, those who are outside also, they got the registration. And we are hoping and looking forward a person like you who is so skilled and who has mastered this field of pain management, and finally after everything is pain related. As I always said that, see, pain is finally the deciding factor which decides whether you are comfortable or you are non-comfortable. Rest all things, variation and fluctuation are acceptable. Doctor, first of all, I really thank you wholeheartedly for joining this conversation and making this program a more glamorous program, because Hello Dotor is running for more than almost 10-15 years now. And people like you who have enriched the viewers with their knowledge and abilities is the success story of this. So on behalf of Prudent Media, our team and viewers, I thank you very much and wish you all the best. Looking forward to see you back in Goa with all your abilities and your skills in practice and in performance. Thank you very much.
Thank you
God
very
bless
much, Dayanand. My privilege and pleasure.
Thank you. Dev
Thank
Bare.